Welcome. We are here in Valencia at the time of the 34th annual meeting of ESGAR, and today we have two experts of liver imaging staying with us and sharing their reflections about liver imaging, the present, the future, and also discussing with us their reflections on Oviglance. So welcome Dr. Nicolaus Kartalis from Stockholm Karolinska Hospital, and welcome Dr. Alessandro Furlan from University of Pittsburgh, USA.
Thank you.
Welcome.
Thank you very much. Thank you.
So we are here to discuss about liver cancer. I would like to start with putting some numbers to this burdening disease. We're talking about primary liver cancer, which is the third leading cause of death related to cancer. However, even liver metastasis having a bigger epidemiology and affecting so many patients out there, 1 million of people are suffering today, and the projections are unfortunately that this is going to be a burden even more in the future. So if I can ask you, Dr. Furlan, what do you think is the role of liver imaging when it comes to the patient care today from a radiologist's perspective?
Yeah, I like to think that liver imaging plays truly a critical role in the clinical management of patients with primary and secondary liver cancer. And imaging plays a number of roles in multiple stages of the management of these patients, certainly in detection of the tumor, in assessment of response of the treatment, and the imaging can also be used as a guidance for interventions needed in the diagnostic or in the treatment phase. We have multiple tools in our bag. I like to think about ultrasound, CT, and MRI. And among the three of them, certainly MRI is the tool that provides most information, and both on the diagnostic and sometimes even prognostic information. So certainly a vital role. Yeah.
Let's think about liver metastasis, which again, we mentioned before is actually the number of cases that hits the most when we talk about liver cancer in general. So Dr. Kartalis, when it comes to the journey of these patients, again, from an imaging perspective, from a radiologist's perspective, how would you describe the journey of a patient, let's say, with liver metastasis?
Yes, that's a great question. Actually, with the improvement of the treatment, the introduction of new treatment methods like systemic chemotherapy, local ablative treatments, local surgery, we have a tendency to see these patients quite often because you treat the lesions, then sometimes they come back, you treat them again, so we follow these patients quite a long time. It's not as previously when people with metastases, they were not amenable to any treatment, but with the new methods we're using, it's possible to treat each and every lesion that comes up. So we follow this patient quite a lot of times. We see them many times.
If we rethink about this journey that Dr. Kartalis has just described, a question for you, Dr. Furlan, which steps do you think are the most critical ones when it comes to the outcomes that you would like to have for those patients?
Yeah, very good question. Because, I mean, certainly all the steps that were described are important. Perhaps, the first one, I would say, like the early detection of cancer, either primary or secondary, is a very important step. Generally speaking, detecting a cancer when in the early stages, when small and confined, gives a situation where multiple treatment options are available, and that usually comes with a better prognosis for the patient. So that's, to me, perhaps is the most important step. Certainly, though, the follow-up that Nikos described is also very, very important, and for that, defining the frequency of the follow-up and identifying the best imaging modality that can provide the diagnostic information along with a good safety profile is key in that direction.
how do you foresee the evolution of the usage of MRI? How would you describe its role today and in the immediate future?
Actually, MRI is the most sensitive technique we have for the detection of liver metastases. And as opposed to CT and ultrasound, you can find very small lesions all around the liver. And this is very important for the surgeons, for the oncologists, because things have been improving in regards to treatment. So they need to have a real good evaluation of the whole of the liver. So 5 lesions in one patient may be completely treated differently from 5 lesions in another patient. And we don't know that beforehand. So we need to use our best modality, and actually the best modality shown in multiple studies and meta-analysis is MRI, and particularly the hepatobiliary phases in conjunction with diffusion and weighted imaging.
Dr. Furlan, so what would you say is the most important factor or factors that you take into account today when you have patients with liver cancer or liver metastasis, and at the same time also having difficulties in the decision making and pathway due to renal impairment? These two conditions can be easily and frequently be seen in the same patient, with the global population aging and comorbidities playing a big role.
You are correct that it's not infrequent to find ourselves in those situations, in managing patients on top of having metastatic disease, also have an impaired renal function. What we are concerned about certainly is the deposition of gadolinium into the body, into the different tissues of the body. As you remember, when the first concerns about NSF came about in 2005, 2006, a lot of attention was placed in identifying the gadolinium-based contrast agent most responsible for that deposition. And a number of guidelines have been placed to guide the radiologist in reducing the amount of gadolinium injected according to the renal function of the patient. Because of those moves that were taken more than a decade ago, the number of reported cases of NSF drastically decreased to the point that now is not a major concern anymore. What we are still concerned, though, is the deposition of gadolinium. We know that all gadolinium-based contrast agents can release gadolinium, even the macrocyclic, and a small quantity of gadolinium can be found in the body, in certain portions of the body, after a few days of injection. Now, what we don't know is what's the clinical implication of that. The ACR, the American College of Radiology, recently accepted a terminology term called SAGE, which are symptoms associated with gadolinium exposure. There is no intention of labeling it as a disease yet because we don't know much about it, and there is a lot of interest in that direction. But certainly there is concern, especially in patients with impaired renal function or in patients undergoing multiple imaging follow-up, about retaining gadolinium. And so the general recommendation is always that of injecting the lowest dose that is clinically diagnostic. And so still in my institution, for patients that have reduced renal function, of course, depending on what kind of reduced renal function we're looking at. But if the patient is not in AKI but has a chronic kidney disease, we would reduce the amount of gadolinium that we inject in the patient. Right. Since we still do not have an alternative, a non-gadolinium-based contrast agent that we can use. Yeah.
Very interesting. And I'm also curious about any geographical differences. Here you're representing clinical care in the US, Dr. Furlan, but maybe in Europe, is it different? Is it the same reflections you would share with Dr. Furlan?
Actually, we are pretty close into the way of thinking regarding these patients. The EMA has also issued some guidelines how to to position yourself against the disease and the potential of the positions in the brain, and for the patients with risk developing NSF. Some agents are not allowed anymore, some others are allowed for specific indications, and we are also concerned in the daily clinical practice and try to minimize the amount of gadolinium that we use for the specific clinical problem that the patient has. So we are pretty close to our colleagues from the other side of the Atlantic.
So Dr. Furlan, if you think about liver imaging and contrast media agent, let's reflect on liver-specific contrast media agent. What do you think the future will look like? What would you expect from the landscape of contrast media agents specifically designed for liver imaging to be?
Yeah. You know, we have currently 2 hepatospecific contrast agents, and they're both linear agents, and they are both gadolinium based, of course. The value that we place on the hepatobiliary phase image is large, as Nikos described before. So the ideal next step, in my opinion, would be high relaxivity contrast agent that could be perhaps, if gadolinium based, could have like a macrocyclic structure, geometry, and provide an hepatobiliary phase, or as an alternative, a contrast agent not based on gadolinium can also provide a strong hepatobiliary phase. We don't have that yet in the market, but it would certainly be a great tool to have in our box. Yeah.
And that brings me probably to our final question here. Orviglance is going to be not based on gadolinium. If you can sum up now all these key elements that we have discussed together, and this is a question that I'm posing to both of you right now. So if you think about Orviglance, what would you foresee be the role, especially when it comes to patients with liver lesions, liver cancer, primary or either secondary with metastasis going on, and this comorbidity being driven by severe kidney impairment? What is the role of Orviglance for you in this scenario? Could you please share your final reflections?
Yes, I think if we would look from the efficacy perspective, for me as a radiologist, it would be ideal to have an agent that the patient can administrate to him or herself without the need of injecting anything at home, then come to the scanner, perform a few sequences that are sufficiently informative for the decision making, and without complications from the kidneys, without the risk for NSF, without the risk for gadolinium depositions in the brain, etc.
Now, going back to the single patient, you know, the indication that comes to mind is screening, again, early detection of cancer. And I'm thinking about our patients with chronic liver disease or cirrhosis that we are currently screening mostly with ultrasound. Ultrasound is a great imaging modality, but has many limitations, and depending on who performs it and depending on the patient receiving it, the quality of the images of the liver may not be diagnostic. There is a lot of, in our community, there is a lot of attention toward using MRI for screening, especially in patients at high risk and those we know would not perform well with ultrasound. So in that context, having a contrast agent that, again, can be taken orally and provides a strong hepatobiliary phase will give us an option for the patients to be screened for hepatocellular carcinoma without the complexity of an intravenous gadolinium-based contrast agent. So I see that as an area of value for the addition of this contrast, for sure.
Perfect. So I would like to thank you both for sharing your reflection here in this liver imaging question and answer session, and hope to have you both with us together soon in another meeting. Thanks a lot.
Thank you.
Thank you.
Thank you very much.